Hi, I'm Philippa Pavia. I'm a board-certified veterinary surgeon, and you'll be watching Suture with me. I wanted to be a veterinarian my entire life since I was about 8 years old. So I went and did an English Lit degree at Yale, which makes a lot of sense. But after that, I went to University of Pennsylvania for my veterinary degree, and I did my internship and residency at the Animal Medical Center in New York City. After that, I started working in Union Square, and I've been working as a board-certified veterinary surgeon there ever since. I also took on the leadership of our internship program and became the medical director of our program as well. But of course, my first love is veterinary surgery, and that's why I'm standing before you today. So most of us surgeons have things we love and the things we think that we should get better at. My first love was soft tissue surgery, but I really came to love orthopedics as well. My practice is general surgery. So I do everything. I do everything from surgical oncology to fracture repairs and TPLOs. Certainly do a lot of that these days. I used to see exotics as well, snakes, birds, turtles, reptiles, but right now my practice is limited to dogs and cats. But I do have experience with exotics and large animal surgery as well. Right now, I'd say the bulk of my practice is dogs under 5 pounds working in downtown Manhattan. So my experience with small animals and exotics serves me well from that perspective. Other experience, certainly, I do a lot of public speaking, a lot of lectures, and a lot of teaching with our interns in our program as well. So as you may know already, the diploma of the American College of Veterinary Surgery now has a designation small animal after it, for those of us who were boarded more recently. So small animal means anything from a gecko or a chinchilla to a 100-pound mastiff. So my experience with small animals is pretty broad. I don't work with exotics anymore, but I do have experience with exotic pets. Right now, my practice is limited to dogs and cats. So people ask me, why do board-certified veterinary surgeons exist? Isn't every veterinarian a surgeon? Yeah, we all are, of course. But I'm here for those cases that may be more complex. Their management may be more complex. Sometimes it's a surgery that a general practitioner would feel comfortable performing, but they don't have the overnight care or the nursing to make it appropriate for them to do that case in their clinic. So not only do I have additional training in these more complex cases, but I also have these incredible resources at my disposal for myself, but also for the general practitioner. So not only do I do surgery, but I'm also there on the phone, over text message, over FaceTime, for my colleagues in general practice who may need that last minute, little bit of confidence before they go into a surgical procedure. So every day when I walk in the door, I'm not exactly sure what I'm walking into. I try to structure my day as much as I can. I'll see appointments, usually about 40 minutes per case, and I try and make my diagnosis and then set my surgery schedule for the next day. When I'm in surgery, I do a mix of everything: soft tissue, orthopedics. Just the other day, I did a fracture repair on a 1-kilo Pomeranian and then turned around and did an amputation on a 42-kilogram Rottweiler with a bone tumor. So every day is completely different. I can't really ever fully prepare for what I have going in there, but that's what I'm here for. I'm the one dealing with these cases that maybe you don't want to. A question I get a lot is, how did you get here? How did you become a veterinary surgeon? Takes a long time. A lot of fun, but a lot of hard work too. So 4 years of undergrad, I did a year of a post-bac to finish my veterinary prereqs. Then I did 4 years of veterinary school, applied for internship, did a rotating internship, a general internship in medicine and surgery. And then I was lucky to stay on at that same hospital for my residency for 3 years of surgery residency. The majority of surgeons these days, however, do have to go through additional specialty internships, even fellowships, research fellowships. So it's a long road. You've got to be pretty sure you want to be a surgeon before you start down it. This is what we're going to be covering in this program. We'll be talking about all the basics of suturing. We'll talk about what you need, instruments, how to hold them, how to use them, when to choose different types of instruments. We'll talk about suture needles, when to use each one of those types, suture types, how long they last, what tissues they should be used in. And then, of course, we'll go into some of those suture patterns and knot tying. There's really only 3 things you need to suture. You'll need a needle driver, you'll need a pair of thumb forceps, and you'll need a patient. Within those, there's a lot of different types. The most common type of a needle driver is just the one you're going to see here, the Mayo-Hagar. Some of them also cut, so you'll be seeing the Olsen-Hagar as well. We won't go too much into the specific types of forceps, but needless to say, you just need one that you're holding correctly. It seems pretty obvious how to hold something with 2 holes and a grip, but it's not. It's very different from the way you would hold a pair of scissors, for example. So there's 2 ways to hold your needle driver. The traditional way is called a thumb and ring finger grip. So it's just the way it sounds. You put your thumb and your ring finger through your needle driver and your index finger down the shaft of the needle drivers for better control. Easy, right? Not so easy. You'll want to practice this at home. Once you've mastered the thumb and ring finger grip, you're going to want to learn how to do another type of grip, which is called palming the instrument. It's also known as the thenar eminence grip. In that method, you hold the needle driver in the palm of your hand. You don't put any of your fingers through the rings and pop, open, and closed without using your fingers. There are so many different types of suture to choose from. How do you know which one you should use and when? A lot of it will be dictated by what you have access to in your practice, but you should definitely know the basics. There's non-absorbable suture, of course, and there's absorbable suture. But within the category of absorbable suture, you also have those sutures that last less time in the tissue and more time in the tissue. When you have a tissue that's not going to need a suture that will be there for a long time and maintain its strength for a long time, you'll want to use one of the short-lasting absorbable sutures. The 3 main types that you'll see, there are more out there, will be polygalactin 910, polyglycolic acid, and polyglycaprone. Say that 3 times fast. So when are you going to want to use one of these short-lasting sutures? A lot of the time, that'll be in a tissue that's going to heal rapidly and that doesn't have to bear a lot of tensile strength. So that will be your subcutaneous tissue and your intradermal tissue. You're not going to want to use one of these short-lasting sutures on something as critical as a linea alba. When you have a tissue that may be absolutely critical, that it maintains its integrity, or it may be slower to heal, that's when you'll want to use a long-lasting absorbable suture. You want it there a long time, but not forever. 2 of the more commonly used long-lasting absorbable sutures are polydioxanone and polyglycinate. They'll be there for several weeks, even months, up to 3 months, but they will eventually be dissolved by the body. Every once in a while, there will be a time when you want to use a non-absorbable suture. That'll be when you want a suture to stay in the body forever, or when you're planning on removing it anyway, like a skin suture. The 3 most commonly used non-absorbable sutures are silk, polypropylene, and nylon. There are 3 main types of needles you'll want to be acquainted with, and the first is the cutting needle. That refers to the tip of the needle, and there is a knife edge on the inside of the needle. Rarely are you going to want to use a cutting needle. This is for really, really tough tissues like tendon, where you need to get through something that's difficult. The downside to the cutting needle is that it cuts, and when you pull the suture through, it may pull through that cut edge. More commonly, you'll want to use a different type of needle, like a reverse cutting needle. In a reverse cutting needle, that cutting edge is on the outside of the needle, so it still makes it easier to get through tough tissues, think your intradermal layer, but it won't put you at risk of propagating that hole when you pull your suture tight. In delicate tissues, or tissues when you want to make sure that that hole isn't going anywhere, you'll want to use a taper needle, where there is no cutting edge whatsoever to the needle and just a very fine point. Think linea alba. You don't want that hole to be getting any bigger than it is, but you need your suture to stay. If you're anything like me, you memorized so many suture patterns in school. At the end of the day, you're probably only going to use about 4 or 5 of them, but we should still know what the different types of suture patterns are and when and where we should use them. Big categories: continuous, interrupted. Most common continuous patterns you'll use will be your simple continuous or an intradermal pattern if you're going to be fancy and you want to bury those skin sutures. Interrupted patterns, most common ones you'll be using will be a simple interrupted, a cruciate pattern, maybe some of those mattresses again if you're getting fancy with some wound repair. If you'd like to grab your suture kit, you can follow along with me. The instruments I'm using today are a Brown Adson thumb forceps, also known as a pickup, and this is a Mayo Hagar needle driver. You may also be familiar with an Olson Hagar needle driver, which has a scissor in the box lock right here. I'll be placing my needle driver about 2/3 of the way up from the point of my needle, between the point and the swaged on end of the needle. Usually, I'll be placing it perpendicular or 90 degrees to my needle as well. I don't want my needle driver too far back on the needle because it will make it more difficult for me to pass my needle through tissues. And of course, I don't want my needle driver too close to the tip of my needle because then I just won't have enough length of needle to pass through the tissue. This is a simple interrupted. Simply place the needle from one side of the tissue to the other and grasp your needle on the other end. In order to tie your knot, pull it through as far as you wish, and you may want to practice handling your suture with your left hand. You can use your needle driver to help pull that suture through. Once you're ready to tie your simple interrupted square knot, you want to place your needle driver in the middle of your incision. Without moving your right hand, you want to use your left hand to create your loop. That creates the most efficiency of movement rather than moving your right hand to create your knot. Again, needle driver in the center of your incision and use your left hand to do all the work. Grasp your tag and ensure that you lay your suture down perpendicular to the incision. Now, for many of your sutures, you may wish to do a surgeon's throw to avoid that loosening of your initial loop, and I'll show you that. A surgeon's throw just involves passing your suture twice around your needle driver. I'll show you that again. Regular throw, surgeon's throw. And what that does is it creates more friction and holds your loop exactly where you want it. In order to finish your knot, you create a square knot. Again, needle drivers in the center of your knot. Use your left hand to complete your action and pull apart. Again, needle drivers in the center, loop, change direction. Needle drivers in the center, loop, and change direction. When you have an incision, keep in mind that you'll want to be suturing from top to bottom or right to left. It's much more difficult if you try and make your pattern left to right or bottom to top. And that's your simple interrupted. Next, we'll do a common suture used in skin, a cruciate. In this pattern, your needle path is exactly the same as with your simple interrupted or a simple continuous. You merely take two passes adjacent to each other and of course it's called a cruciate because of the cross shape made by your suture when you tie it. Again, I usually choose to do a surgeons, and for the sake of this demonstration, the surgeons will keep the knot in position more easily. Needle driver in the center, 2 loops around your needle driver, grasp and tighten. 1 loop to lock it down, and you'll tighten it like so. One trick, if you do not want your knot to tighten the entire loop of the suture, but you just want your knot to tighten down, you can close your loop down, and when you're almost at the point of tightness, lift your hands gently, and that will help tighten your knot and not the loop of suture. Next, we'll do our most common suture pattern for linea alba or other tissues in which you want to use fewer knots and distribute your tension across an entire line. This is a simple continuous suture pattern. Start with your simple surgeon's knot, 2 loops, tighten down, another loop, tighten down. Depending on your suture material, that will determine the number of throws that you want to make to start your suture line. Remember that each time you pass your suture around your needle driver, that is 1 throw. So that's 3 throws, and that would be 4. To continue your simple continuous suture line, do exactly as you did. Over the remainder of your incision. Of course, your patient would remain in place without pressure. When you've completed that simple continuous line and you want to end your suture pattern, leave yourself a loop, not too long, not too short, just enough to create your knot. You do not want to use a surgeon's throw at this point because you already have more suture and you don't want to add bulk to this knot. So, interrupted, single pass, grab your loop and pull it through. If you have tension or drag on your suture line, you may wish to grab each limb of your loop individually in order to fully tighten your line. Complete with a square knot. Again, number of throws will depend on the tissue and your suture material. Now, this is going to be a little bit tricky on this material, but I will try and show you how to bury a knot and begin an intradermal pattern. For burying your knot, you'll certainly want to manipulate your hand as best you can. Again, this is where I like to do the palming position of the needle driver versus the thumb and ring finger grip. But wherever you're most comfortable with is what you should use. In order to bury your knot, you must start deep. And always remember, if you're right-handed, go with your needle. So I'm going to start my deep loop on the near side of my incision. And the reason that's important is I want my suture end to be deep within the tissues. I'm going to come back to my other side and gently manipulate my tissues so that I'm entering the tissues superficial and exiting deep. So you'll remember that mantra, deep to superficial, superficial to deep. And there, my knot will be buried. So let's do a buried intradermal, or some call it subcuticular pattern. Starting with our buried knot, deep to superficial.
superficial to deep. And in a patient, I would be ensuring that I'm engaging the dermis in this more superficial layer, placing my square knot under the skin, and a surgeon's or a single square throw is appropriate here. If this is some of our more common monofilament suture, I'll often start with 4 or 5 throws. If you're interested in the right number of throws for your suture material, you can actually look that up depending on what it is you're using. Of course, we would be cutting this knot short and it would be buried. And then continuing my suture line, unlike your simple continuous where you're taking your bite perpendicular to your incision, for your buried intradermal, you're taking your bite parallel and skimming the surface of the skin, engaging, just as the name says, the dermis. In order to do a cosmetic closure, you want to make sure that your bites are as equal as possible. You want each of these sutures to be coming out almost perpendicular to your incision line. You'll know you've taken too big of a bite if your suture gaps and your tissues gap. Just like everything else, practice makes perfect here. Once you're done with your intradermal line, I'll pull it closed there for argument's sake. I like to actually test myself and try and pull the tissues apart to ensure that I've placed my bites evenly. Now, we'll start the difficult task of trying to bury our knot. For this, we're going to want to make sure that when we start our knot, it's going to happen in the most ergonomic orientation for most right-handed users. So I want my knot to be buried, so I will start using my right side of my incision, superficial to deep, and this is going to be the beginning of my deep loop. Superficial to deep, deep to superficial. Now, don't pull this one through all the way. This is your deep loop. We'll be tying to this. And as you can see, these loops are coming out deep in the tissues, and that's what's going to keep your knot buried. All right, so now we're superficial. We got to get back down into the deep layer to be able to tie our knot. So again, superficial to deep. This is one of the trickiest parts. Make sure your needle ends up just next to your deep loop. So, deep loop, deep suture end. This loop can be pulled tight, all right? So with a buried knot at the end of a continuous suture pattern, all 3 of these pieces of suture must be coming out from the deep tissues. Finish just the way you started, square knot. Again, you may want to grab each limb of your knot individually to fully tighten your line, placing your needle driver in the center of your incision, exchanging hand position, center of the incision, left hand does all the work, and changing hand position. Now, if this were a patient, I would be cutting this loop very short. And most likely, what I like to do to fully ensure that my knot is buried, I like to re-enter the incision, pass my needle deep, and this is called smurfing. Pull that knot deeper into the tissues. And you can see in the phantom here that when I do that, it pulls that knot deeper into the tissue. And once that knot has disappeared, now I can cut my suture end. And that is a buried intradermal pattern.
When I first scrubbed into the surgery and I was there in the OR, I thought the knots were basically magic. I had no idea how I was going to learn to do any of those things. Well, thank goodness now we have the internet, so you can watch a lot of videos about it, but also you're going to have to practice. What I did was I sat there on the sofa. I had my Phantom, I had a pair of needle drivers, and whatever I could get my hands on. I used expired suture, I used shoelaces. A phone cord can even be something really useful to learn to do your hand ties. So that brings us into the different types of knots. The two big categories are hand ties and instrument ties. The majority of the time you will be using an instrument to tie your knots, but there will be times when you won't and you'll just want to be able to use your hands. Now, I'd like to demonstrate some examples of these surgical knots.
Hand ties are a type of suture tie that is much more common on a pedicle, such as a neuter or potentially even for the uterine body when you're doing an ovariohysterectomy. For the sake of example, I'll use the needle to anchor in the tissue. There are multiple different methods of learning hand ties. What's important is that you have two lengths of suture that are of relatively equal length, and you remember where your needle is because you don't want to be manipulating and passing your needle around. So, depending on where your needle is, that will tell you where you want to start with your hand tie. I'm doing a right-handed single hand tie. I'm taking my needleless portion on the right, and I'll create a 4, sticking my index finger and looping it into the suture, creating a 4, and then bringing that tail through. Always remembering to cross your hands over to create that appropriate first throw. Then I will never drop this single piece of suture, and using it between my thumb and my forefinger, I'll gently loop it back upon itself. With my left hand, I'll bring my other piece of suture with the needle attached. Remember, I'm never going to be manipulating it any more than that. And then I'll use my middle finger to bring that free loop around. And you can see that we're laying down a square knot right there. Again, next throw, create a 4, bring the loop of the 4 through, switch your hand position. Loop your free end over your hand, bring your needle end over, and using your middle finger, bring that loop through. And for the sake of demonstration, I've left these loops open so you can see how the square knot will lay down.
Let's go over what we learned today. We started out with the basics, instruments, what you need, what you have to suture. Then we talked a little bit about how to hold those instruments. We talked about the anatomy of the needle. Then we went into the different suture types and when to use them. Finally, we did some suture patterns and ended with knots. If you have any questions, put them in the comments below. And if you'd like to connect with me, you can find me on LinkedIn. Thank you so much for spending your time with me today. This concludes the surgery certification program brought to you by PRN Pharmacal. The next step for you is completing the certification process by passing a quiz. In the comments below, you'll see a link to this quiz. Once you pass the quiz, you'll receive a certificate of completion and another link that will direct you to tools to celebrate, recognize, and share your accomplishment. If you have any questions, please email us at hello@myvetcandy.com. Don't forget to like, comment, and share. Thank you again for watching.